Good evening to everyone and welcome. Thank you for joining us as we close out what is unbelievably already the second week of January. My name is Ryan Googe, and I am the Executive Director of the Partnership to Advance Cardiovascular Health, which we call PATCH for short. First of all, I want to thank Amgen for sponsoring tonight's webinar. PATCH is a coalition of clinician, doctor, nurse, and patient organizations that work for better healthcare for people living with heart disease. You can see on the slide on the screen the many organizations that we collaborate with. PATCH's mission is about helping people. We want to make sure that anyone who has had a heart attack or stroke, or anyone who is at risk for having a heart attack or stroke, can get the care that they need to live long, productive lives. We at PATCH have the opportunity to work with a lot of amazing clinicians and patients who are remarkable advocates, people who have persevered through trying times and are also are the leading lights in heart medicine. Some of those advocates are here with us today to have a heart-to-heart with you. So how do you live life once you've had a serious event like a heart attack or stroke? And how do you manage risk if you know you could have a heart attack or stroke? Is cardiovascular disease preventable? And what are the best practices for keeping your heart healthy? We'll address those questions and others tonight with our speakers. Our first speaker tonight will be Dr. Robert Busch, who is a board-certified internal medicine, endocrinology, diabetes, and metabolism specialist at the Endocrine Group in Albany, New York. Following Dr. Busch, we will hear from a fellow New Yorker living with heart disease, Marianne Heusler. Everyone watching us live this evening should please feel free to ask questions in the Q&A box, which you'll find just below the feed, and we'll do our best to incorporate the questions in our discussion. So with that, I'd like to invite Dr. Busch to the screen, and we'll start our clinician discussion. So Dr. Busch, so glad to have you with us. Thanks so much. Happy New Year to you. Feels like 2021 just kind of blew by us there. So thanks for being here.
Thanks a lot. Thanks for having me.
So we're going to talk a little bit about heart disease, but you are an endocrinologist. And so I'm really excited to get at what endocrinology is and the interplay between different diseases and cardiovascular disease and how all of that kind of factors together. And I think you will be able to speak to that very well. But remember, we organize this webinar as a source of information for people who have either had a heart attack or stroke or know that they're at risk for one because of their family history and that kind of thing. So let's start with kind of a level setting question for folks that may not know about endocrinology. So, folks, generally they understand who their primary care physician is. They have a pretty decent understanding of what a cardiologist is, a heart doctor. But to get us started, can you shed some light for us on what an endocrinologist does and how endocrinology relates to cardiovascular disease?
Sure. So an endocrinologist is a clinician who sees patients with internal secretion gland problems. So this isn't swollen glands in the neck like an ENT doctor, but we do thyroid disease that puts out a hormone into the bloodstream, or pituitary disease that puts out hormones. But the main thing endocrinologists do are treat people with diabetes, where there's either no insulin made by the pancreas, type 1 juvenile diabetes, or more commonly, type 2 diabetes, where the pancreas makes insulin, but not enough insulin, usually for an overweight body, and therefore the consequences of having high blood sugar over a period of time. If you think of sugar as damaging the lining of blood vessels, it could damage small vessels in the eyes and the kidneys and in the feet, and more importantly, big vessels in the heart, in the neck for strokes, in the heart for heart attacks, and in the legs for vascular disease and amputations. So basically, we become amateur cardiologists. So when I walk in the exam room with a patient with diabetes, the first thing I'm thinking is, how am I going to prevent your heart attack or stroke?
Got it. So tell me, how long have you been practicing medicine?
Probably before you were born, Ryan. No, so I started in practice in Albany in '84. I did my training and internship and residency in Long Island and then came up to Albany for fellowship. And I've been in practice since '84.
So tell me, I'm just curious from your perspective, looking at the prevalence of diabetes over the course of your career, like what's the trajectory been like since '84?
Well, I can tell you that my group in Albany, we usually call it Smallbany, has 15 endocrinologists in the group. So you can imagine how common diabetes is. It's become very specialized because primary care docs have to take care of everything. You know, they have to know how to treat COVID, and they have to know how to treat diabetes and how to treat an earache and all that, where we have to know a lot about a little. We have to know a lot about how to lower the blood sugar and what other drugs we can use to lower cardiovascular risk. How do we treat lipids, cholesterol? How do we treat triglycerides, another lipid? How do we lower blood pressure? So basically, endocrinologists become like the internist for patients with diabetes, and we worry about all the complications that high blood sugar can lead to in the long run.
So how many, can you break down for us, I'm just curious, the percentage of people that you see that have already had a heart attack versus those that you're trying to prevent maybe a heart attack?
Well, if I'm doing my job right, hopefully no one will have a heart attack. But I have a lot of people who come to me with diabetes and heart disease to start with. So I would say I can tell you I'm director of research in my institution, and we have no problem recruiting diabetic patients who have had heart attacks for studies. In fact, we're usually the top site in the country for many of the drug studies. And the reason I'm saying that, many diabetes drugs are being tested now. Will the diabetes drug, besides lowering sugar, also lower heart attack and stroke and death? So the public is very aware of this when they see TV commercials for some of the drugs like Jardiance and Ozempic are drugs that are diabetes drugs that, oh, by the way, they've been shown to lower death or lower heart attacks or strokes. So the diabetes drugs now not only are being utilized to lower sugar, but specifically they're heart smart diabetes drugs that lower heart attacks and strokes and death as well.
We talk a lot about this in the policy space. So I think the stat that I know is that if you're and tell me if I'm wrong, but if you're diagnosed with type 2 diabetes, you're 2 to 4 times more likely to have a heart attack.
Exactly right. And if you've had diabetes and have had a heart attack already, you're much more likely then as well. So someone with diabetes who's had a heart attack or a stroke and who survives is much more likely to get another event. And those are the patients we particularly want to focus on. We want to focus on all of them, but particularly someone who survived their first heart attack because they're extremely high risk for their next heart attack.
So can you talk to us a little bit about when that kind of shift or this understanding that there was this connection between diabetes and cardiovascular disease really kind of became embedded in practice?
So it's always been known that patients with diabetes succumb of heart attacks and strokes, even though they may get small vessel disease causing blindness and kidney failure and nerve damage and loss of limb. It was always known that the patient with diabetes succumbed of heart attack or stroke, particularly if they had underlying kidney disease, but not necessarily. So that's been known for years, but it was never known that lowering the sugar by different means can also lower heart disease. It was always felt if you lowered the sugar, you'd avoid blindness, kidney failure, and loss of limb, but it was not felt that just keeping the sugar controlled lowered heart attacks and strokes. That has changed in the last 5 years when some very big drug studies have shown that when looking to see if the drug was safe for the heart, we actually found that these drugs were beneficial for the heart, that they also not only lowered sugar, but lowered heart attack, stroke, and death. We refer to that in medicine as MACE, multiple adverse cardiac events, MACE, which is non-fatal heart attack, non-fatal stroke, or cardiovascular death from a stroke or a heart attack. That's what MACE is. And these drugs are studied what their ability is to lower MACE. Do they lower either a heart attack or a stroke or dying?
So you're touching on a question here that I wanted to ask you. So let's back up a little bit for folks. Uh, let's talk about disease classification, because I think a lot of folks will have heard, we're working on primary prevention versus secondary prevention. So can you talk a little bit about what is the difference between primary prevention and secondary prevention? And then, well, let's start with there, and then I have a follow-up for you.
Okay, so primary prevention is to prevent the first event. So, for example, most of our patients take a statin to lower their LDL to prevent a heart attack. Statins have shown that they lower heart attack, stroke, death by 37%. So I'm sure the audience are very familiar with statins, so the brand names Lipitor, Crestor, Zocor, or the generics statin, simvastatin, rosuvastatin, atorvastatin. I'm sure if you're dealing with a cardiac audience, most of the audience is on that. So, for example, I take a statin to prevent a heart attack. I've never had heart disease and I don't want heart disease. That's primary prevention to prevent your first event. On the other hand, secondary prevention is someone who's already had an event in the past. They've had vascular disease in the legs, or they've had a heart attack, or they've had a stroke, or they've had a stent, or they've had an angioplasty or TIA mini stroke already. They've already had an event and they want to prevent the next event because, as you know, the next event could be fatal. The first event could have been, but if they lived through the first event, they want to prevent the second or third or whatever event. So that's what secondary prevention is. And in general, when drug companies study drugs, they always like to study secondary prevention because you get your outcomes quickly. Because if you have a bunch of people who've had a heart attack or a stroke, they're so much more likely to have another heart attack or stroke over the period of time you're studying them, that if your drug works, you'll prevent the event, and you'll have the drug will work better than not being on the drug. Whereas if you're doing primary prevention, you have to treat patients and a lot more patients a lot longer to show the difference in the two groups.
So that kind of leads me to my follow-up question is, can you put a finer point on it, how important it is once you've had that first heart attack, like what your risk is for a second one, and how important it is to manage your heart disease, and also your comorbidities, these other problems you're dealing with, like diabetes or kidney disease or some other things you may treat. Can you put some finer point on it and help people understand like how important it really is and what your risk is after having one that you might have another attack?
Yeah, if you had one event and survived, because as you know, many people don't survive the first event, your risk of getting another event is much, much higher than someone who has diabetes or hypertension or smokes or whatever to get the first event. So the risk is multiplies dramatically, probably 4 to 10 times more likely to get the event, another event. It might be 20% of people or 10 to 20% of people who've had a first event will get a second event in a relatively short period of time over the next couple of years. So those are the patients you particularly want to go after. They survived their event, they had their heart attack or their bypass surgery or their stent or whatever. And now you want to really blitz them with not only with lifestyle and diet and exercise, but with appropriate medications if they can afford them and if they can tolerate the potential risk of the medicines to avoid their next event, because the next event might be a fatal one or might be even more severe than the first event.
So someone dropped a question into the chat that I want to ask you, Dr. Busch, and it fits in nicely where we are right now in this conversation is, so as someone who's had an event, I've had an event, what is the number one thing that I can do to prevent another attack? If you were to say there's one thing you need to make sure that you're doing, what is that?
Well, if you smoke, stop smoking. If your LDL is high, get your LDL cholesterol down. If you have high blood pressure, get your pressure down. And the nice thing, we could do all of it. You're not just doing one or the other. It's like, who do you love more, your son or your daughter? You love them both. And the same thing here. You want to control everything controllable. You can't change a family history, but you can stop smoking, lose some weight, exercise within moderation, and very importantly, get your LDL cholesterol way down. There's a target below 70, and below 70 means below 70. 71 is not below 70. Get your blood pressure down, and if you have diabetes, be on heart smart diabetes drugs. So I know people may not want to hear this, but the typical patient with diabetes who's had heart disease is probably on 6 or 7 different medications in addition to their healthy lifestyle. We're getting their LDL down dramatically. We're getting their triglycerides down with a heart smart fish oil such as Vesipa. We're getting their blood pressure down, and we're getting their sugar down with drugs that are particularly beneficial to the heart. So they may be on 5, 6, or 7 drugs just for their cardiac benefit, because each one wants to lower what we call the residual risk. In other words, the statin might lower you 37%, but what about the 63% of people who are going to get a heart attack despite being on a statin? So then the blood pressure drug may lower you more, and the smart diabetes drug may lower you more. So each med you're adding will lower that residual risk until it lowers it dramatically.
So we got a question earlier, but I think it fits in nicely with where you're going right now, and it's about diet. And I think that a lot of folks, struggle with diet and have difficulty, sticking to one. How do you encourage people or talk to people about their diet so that they don't, I think people have a hard time sticking to a very strict diet. Do you have any advice for folks on how to, don't beat yourself up about, skipping a day, or how do you normally advise people on a diet, when you're working with them on these issues?
So it has to be something they can live with. Many of our patients, we're spoiled. They see a nutritionist or a dietitian for a one-time visit. Diet most physicians took 1 week of medical school or less talking about diet, where we learn half your plate is green, a quarter is fish or chicken, and a quarter is starch. Most people, 98% is starch and nothing is green. So, they call it Mediterranean diet, or fruits and vegetables and those kind of things, and less red meat and more fish and chicken, and more vegetables and less carbohydrates would be an easy one. But find something that works for you. And sometimes the nutritionist will work out with what you like to eat and incorporate those things into the diet as well.
Got it. So as an endocrinologist, as we've been discussing already, you're working with people with multiple chronic conditions. And we call that in the medical world, we call them comorbidities. So oftentimes with cardiovascular disease, which we're talking about diabetes, and kidney disease, and you touched on this a little bit earlier, but if you could put a little finer point on it, can you talk about comorbidities and their relation to heart disease? And we've talked about diabetes. Can you talk a little bit about kidney disease as well? I assume you see a lot of kidney disease patients as well.
So it's not uncommon that people who have diabetes have kidney disease. Diabetes is one of the number one causes of going on to dialysis. Now, of course, we want to head it off before they go on dialysis. So we try to aggressively manage the blood pressure. We tell our patients with kidney disease, don't take Motrin, Advil, Indocin, or Celebrex. They could take Tylenol because those other drugs can harm the kidneys. We keep their blood pressure down with appropriate drugs that benefit the kidneys. And if they have diabetes, some of the diabetes drugs specifically benefit the kidneys. So that, again, adds to their burden of medications, because now we're talking about we want to benefit the heart with the statin and heart smart diabetes drugs. There are some kidney smart diabetes drugs, and we have to take, and certainly we don't want to give a toxin such as Motrin or Advil, an NSAID, to someone with kidney disease that can harm the kidneys. And maybe people don't realize that because they're over-the-counter drugs and they just take them and no one educated them about that. Mm-hmm. So if you have diabetes, you should know what your kidney function is. It's called your creatinine, or your glomerular filtration rate. Your physician knows that, and you could ask them, because oftentimes they don't get to discuss it with the patient because the patient doesn't feel anything. So they don't know they have kidney disease, and the physician's so busy talking about lowering heart disease and their diet and lowering their sugar, but doesn't even tell them that they have mild kidney disease, and the patient doesn't know that. And kidney disease itself is a risk factor for getting heart disease. People with kidney disease are much more likely to get heart disease. They say what goes on in the urine reflects what goes on in the blood vessels elsewhere. So if you find microprotein in the urine, that's someone you want to be particularly cautious with to avoid heart disease.
What percentage of patients do you see that you think have kidney disease, diabetes and kidney disease?
Very common, maybe 10, 15% of our diabetics have some kidney disease. It may be very mild. They're not on dialysis. I mean, my job as an endocrinologist is to prevent people going on dialysis, just like to prevent someone getting a heart attack. So I'm preventing a lot of stuff. I'm doing a lot of primary prevention to prevent your kidney disease, your heart disease, and really what we go through since diabetes, sugar is in all the blood vessels. We eyes, heart, kidneys, feet. So they all see an eye doctor. They may see a cardiologist who had a stress test or something. They're on a statin. They're on blood pressure drugs. When it comes to kidneys, we avoid drugs that can harm the kidneys like NSAIDs, and we look at the patient's feet and feel the pulses and all that. So that's very common that we look for complications from diabetes, not just, I want to lower your blood sugar, but we're doing all those things at the time during the visit.
You're walking right into my next question. So, we're talking about, a lot of different medications that people are on, potentially a lot of specialists that they're seeing. That can be overwhelming. So my question is, patients who have comorbidities likely see a number of specialists. How is care coordinated for those patients? And who is the quarterback with all these folks?
Well, very good. So sometimes the primary care doctor is, and if you have a very good primary care doc, they could do as good a job with diabetes as we would as an endocrinologist. But oftentimes we're the quarterback. So when I see the patient for their follow-up, who's your eye doctor? When did you last go? Are you on a statin? Is your LDL below 70? If you've had heart disease, who's your cardiologist? When was your last stress test? Did you have a carotid ultrasound? Kidneys, don't take Motrin, Advil, Indocin. Don't get any X-ray dye studies if you can avoid it. Is your blood pressure controlled? And you're on the type of drug called an ACE or an ARB that protects your kidneys? And did I look at their feet? Do you have a foot doctor? So personally, for me, if I'm taking care of someone with diabetes, I'm the quarterback, but I'm still informing the primary care doctor about what's going on. But it's not like, whose turf is it to control the cholesterol? Is it mine? Is it the primary care? Is it the cardiologist? It's all of ours. So whoever does it should do it. And if someone didn't do it, you feel free to do it. I'm not stepping on their turf because I'm benefiting the patient.
So what is your advice to patients who are juggling all of these different medications, the different doctor's visits? The patients that do it well, what are they doing to keep it all straight?
The patients are doing it well, know what they're on. They're not on a heart pill and a water pill and a cholesterol pill. They bring in the pills. They know what they're on. So that's very important. They may bring the lab test from the other physicians so they don't have to get superfluous other tests done. Or they ask you, please send my labs to my cardiologist because my cardiologist wants to make sure my LDL cholesterol is at goal. So someone should be steering the ship. So it's not that 5 different people are prescribing, for their blood pressure. So who's going to take care of that? Some of my patients might say, my cardiologist does my cholesterol. The cardiologist I utilize, no, I'm doing the lipids in my patient. I feel very comfortable doing the statin or doing the injectable, say, Repatha or Praluent, or doing the Vascepa. So they know I will do the lipids in their patient. Whereas other partners of mine, I'll do the sugar, but the cardiologist does the lipids. But someone has to do it. So someone has to be responsible for that with those multiple other risks for heart disease.
So let me ask you, I got a question in the chat here about anxiety. And this actually hits close to home to me because my grandfather is in his 90s and still pretty healthy, but has some heart issues. And God bless him. This week, he was having some anxiety issues because his blood pressure was getting high. He called his cardiologist, and his cardiologist said, chill, it's okay. But my question to you really is, can you talk a little bit about anxiety and mental health and how you talk about that with your patients and the importance of it? And if you see high anxiety among your patients and how they might deal with that?
Yeah, so that's very important as well to deal with. Anxiety can raise blood pressure and other stresses and raise your adrenaline and not be very good for you. So what's the source of the anxiety? Is it that you have diabetes in general? Is it you had heart disease? Are you worry about not seeing your grandchildren grow up? So delve into the source of that. Often the primary care doctor will do that, but everyone plays a role in that as well. But make sure the patient seeks care for that. Don't just treat the cholesterol and the blood pressure and the sugar in this and forget that there's a patient behind there in a very real world situation with other things. Some people are anxious, they can't afford their meds. Am I going to eat or take my medication? Or they have to they can't get the med because managed care has to do a prior authorization. There are lots of things behind the scenes. But mental health and anxiety is extremely important. And the patient wants to feel well in general. What good is it if all your numbers are normal and you don't go out of the house because you're anxious and can't enjoy your life? So you want to be able to enjoy your life as well and not have the medicines be overly sedating if you're not doing well on the medicine. And there are some meds that help with anxiety besides counseling and things like that.
So, and again, you're walking right into my next question. It's a good one. I think we're talking about a lot of medications that folks are on that you work with. It can be very expensive. What can you talk a little bit about access? What should a patient do if they're having issues getting insurance to cover their medications that are being prescribed? And can you talk about assistance programs and how, consulting with you, not being afraid to consult with the physician about these issues and how you kind of work through some of these things?
So we find that happens sometimes. You prescribe a med, you assume the patient's insurance will cover the med, and then they come back and they're not, it was too expensive. I couldn't afford that. And that's the heart smart drug you wanted versus the cheap generic that you didn't want. So there are ways, many physicians have samples. Physicians have vouchers that can offset the copay for commercial insurance. Sometimes there are free programs, even for Medicare, that you can get the trial of the first month or two free. Many clinicians have someone in the office whose whole job it is to do the prior authorizations so they can afford the medication. And many of the pharmaceutical companies have programs for patients who can't afford their meds to make them more affordable to the patient. And of course, when everyone hits the donut hole, and they, oh my God, I'm gonna have to spend a couple of $1,000s to get through the donut hole. And that can happen very early for some of these very expensive drugs. But that's one of the biggest obstacles we have, particularly with Medicare, because the commercial insurers, usually if the drug is covered, there's a voucher that knocks off the copay. But congratulations, you're 65, you made it. Welcome to Medicare. You can't use any vouchers anymore and your drugs aren't covered anymore. That's a rude awakening. So, as one who has commercial insurance, even though I'm Medicare age and I don't use Medicare because I'm working, I dread the time when I have to go on Medicare and give up my expensive meds because I won't be able to afford them. Even as a physician, some of these are very expensive and I have to look into what plans cover what even beforehand with the different Medicare plans. Whereas when you have commercial insurance, you could use vouchers to knock off the copay so the meds are more affordable.
How prevalent do you think these issues are around access? I mean, do you see that the majority of your patients have difficulty with access, or do you feel that it's, I'm sure it varies practice to practice, but I'm curious about your experience and that of your colleagues.
But one of the best parts of my practice now, which was only relatively new, is there are companies that work for hospitals that do the prior auth pull-through. So that's their whole job, is to do the prior auth because the meds are ordered through the hospital specialty pharmacy. So the hospital pays for a company to do the prior auths so that they could get the prescriptions through their pharmacy. But oftentimes you're really relying on the person in the physician's office who might be their nurse or medical assistant. And, the part of their job is to do the prior auth, but that's not the fun part of their job to do that. So they may not be as diligent as they could be to get the prior auth because it does take time and it's not a very rewarding thing to try to do that. Even to order an MRI or a CAT scan or other tests require a prior auth because those are expensive tests. So you have to find that advocate in the office who is doing that. And if you have to be nice to anyone in the office, don't make it the doctor, make it that prior auth person, because they're the ones who are going to get the pull through to get your medicine to be affordable for you that can save your life.
So it sounds like really the short answer is that there are resources for folks, but it's important to speak up and to work with your doctor and to be upfront with them about this, early on in the process.
Correct. That's very important because no matter what meds you prescribe, if the patient doesn't put it in their mouth, it doesn't count just because it's on a piece of paper that you recommended it or sitting in the pharmacy and not picked up.
Right. So Dr. Busch, final question here, just to wrap up. I want to ask you, maybe you have one of these situations, and I'm sure you've had, you're next to you're with a family whose father or mother or aunt, uncle has had a heart attack. They realize that they're type 2 diabetes, they may have kidney disease, whatever it may be. What's the most important piece of advice that you give the family as they're looking to recover from this life-threatening event and move forward with their lives, knowing that they've, faced death, frankly, but they're in a new phase of life and they need to, figure out how to live a new one? What's the biggest piece of advice that you give to those folks?
There's tremendous hope now. Medicine is miraculous. Even over my career, when I started with diabetes and patients had heart attacks and strokes and very commonly and heart failure and coming in with oxygen, and that shouldn't happen. It doesn't happen as much now. It's rare, and a lot of this is preventable. So preventing the first heart attack is important. The primary prevention, don't wait till you have the heart attack. Say, oh, I'll take my statin then, or I'll stop smoking then, or I'll control my blood pressure then. Do things right from the get-go to prevent the first one. And if you're fortunate enough that you had one and survived, prevent the second one. There's lots of tools to do this. Besides lifestyle and diet and exercise, there are many medications that can be beneficial to lower your risk of a second event, and certainly even to lower the risk of the first event.
One follow-up question. Would you say, I'm just curious, over the course of your career, do you feel like that we're in kind of a new era of medicine in terms of innovation?
For sure. If you have to have diabetes, this is the best time ever to have it, because we have so many meds that are beneficial. Besides diet and exercise, we have so many drugs that are beneficial to patients that can avoid heart disease and kidney disease. And, I don't have anyone blind in my whole practice now. I have hardly anyone who's lost even a toe. This is so different than years ago, where you'd have a 30-year-old who's had an amputation and on dialysis and blind and who had a heart attack. A horrible life. Now it's very different than this. The best thing I could hear in practice is, you know what, doc? I've lived longer than any of the men in my family have before me, any of them. Well, that's music to my ears. That's my report card. So I don't take all the credit for it, but that is my report card when a patient says, I've outlived everyone else in my family. So my worries with the patient is they're going to get Alzheimer's or get some horrible cancer because they didn't have a heart attack. They didn't have kidney disease. All the things that I wanted to prevent with diabetes, I prevented, but now they're older and they're getting other things, that I couldn't prevent.
Right. But I think it points that, first of all, I think your point is well taken, that there is hope, which is great. And also it's important to keep perspective where we've come from. And it is exciting. It's time to be in right now in medicine. So Dr. Busch, I want to thank you so much for your time. What a fascinating discussion. As I said, we had not had an opportunity to really talk about these comorbidities on this series yet. And so really appreciate your time and your expertise. And we hope you're well and be well this new year. Good luck this year. Thank you so much.
Thanks, Ryan. You're excellent at what you do. Thank you.
Thank you. So I want to invite my colleague, Grace Freeman, to the screen now. Grace is going to interview our patient, Marianne, and we're very excited to hear. I think it's so important to have the patient perspective as well. I think that a lot of times as a patient, it can be lonely. And so it's really good to hear from other folks who've been through it. And so Grace is going to lead our discussion with Marianne. And Grace, you can take it away now.
Marianne, hi. We are so glad to have you here with us today. Hi, welcome. Just want to start off by saying thank you so much for your work with Women Heart and volunteering your time to share your story today. Marianne, it's important for folks to hear from people navigating their heart disease journey. Dr. Busch gave us a great overview, but as you know, as an advocate, there's a lot to learn from the lived experience. So I'd love to just start by giving our listeners, a little bit about you. Tell us about yourself, where you're from, what you do for a living, and especially what you do for fun.
Well, I live in New York City, and I am a former teacher. I taught at an all-girls school on the Upper East Side of Manhattan for many years. I'm also a mystery writer. I've published 13 books and hundreds of short stories, and that's it. I love to exercise. I'm a runner, And I love to be in Central Park.
Well, Marianne, I'm going to have to read one of those novels one day for sure. But you mentioned Central Park and you mentioned running. And I do want to share with everyone on that Marianne survived an unexpected heart attack. Since then, she's come a long way mentally and physically, and there truly is a lot to learn from your journey, Marianne. So I'd love for you to just give the audience a rundown of the day you experienced when you had your heart attack.
It was July 15th, 2014, and I was going out for my usual run. I usually run 3 to 5 miles a day, a couple of times a week. And it was a very warm day. I didn't expect that anything would be different. I left my apartment and went to Central Park, and I was running, and I was around the bridle path and listening, obviously. Ironically, I was listening to Staying Alive. And all of a sudden, I got this pain in my chest. And it was like an elephant was sitting on my chest. And I thought, this isn't good. But I thought maybe I was at the gym the day before and I lifted very heavy. And I thought, you know what? I must have tore something. And it didn't really occur to me that it was a heart attack. So I left the bridle path and I started walking towards the boathouse. And those of us that know the park know that that's about maybe a 2-mile walk. And as I was walking, it wasn't getting better. It was getting worse. And I was having a hard time breathing and I was sweating, but it was hot out. And I remember that I saw these people running and laughing. And I thought to myself, gee, I wish I were them and I wish I didn't hurt so much. And then I thought, well, could this be a heart attack? Maybe I should stop at urgent care on my way home and let me check it. And I kept walking and walking. And the next thing I remember is that I was in an ambulance and people were leaning over me saying, you have had a heart attack. Do you hear me? You have had a heart attack. And then they said, if we're going to put some nitroglycerin under your tongue, and you hear what we're saying, stay with us. And it was almost like surreal because I couldn't believe that this was happening. Now, I didn't realize it at the time, but what had happened to me is while I was walking to the boathouse, I fell. And a kind runner and a bicycle rider stopped when they saw me fall. And they contacted 911. And said, I think we have somebody who's in trouble here. And I kept trying to get up. This is what they told me. They said, you kept trying to get up saying, I'm fine. Let me go home. I'll be okay. And they're like, no, you can't go home. And I was vomiting and I was lucid enough to give them my husband's phone number, which was important because when, he came to the hospital with my son, my niece, whatever. But more important than that, we were able to do caller ID. So I was able to get in touch with the women who really saved my life and took them to lunch. And they told me what was happening and how they got the ambulance. So they brought me to Lenox Hill Hospital and I went into cardiac arrest and they operated on me immediately, put in 2 stents. And as I was coming out, they told me, you had a widowmaker, which was very serious. I was like 97% blocked. And they said that, I was going to intensive care. And I thought, gee, that doesn't sound good. I feel okay. Intensive care, I guess this was serious. Every cardiologist that came into my room said to me, if I had been any further away, if I had been 5 minutes later, I would not have survived. I would have gotten to cardiac arrest and I would have died. And what's really important is that a week later, we were going to the Cape. I was going to Cape Cod with my siblings. We always rent a house every summer near the shore. And I always would get up, early before everybody else. And I would run along the shoreline. And I love running, in the ocean and just me and the waves and the sea by myself. And I would have died. I would have just died. If I had a heart attack there, that would have been it because I would have fallen, of course. And nobody was around. And by the time they got to me, I would have never been able to get to a hospital in time. They would have had to airlift me because, there's only one hospital at the Cape, and it's in Hyannis, and, so I never would have made it. So I was in the hospital about 3 or 4 days, and it was very scary because when I think that I left the house, I left the beds unmade, bills that I was going to pay, and, the chances that I would not come back, it was, I got to tell you, it's a very scary thing. So that's my story.
Oh, every time I hear that, it just gives me chills. We're just so grateful to have you here with us today, and specifically grateful that, you're willing to share your story with other people. How are you feeling today, Marianne? Are you still as active?
I feel okay. I was listening to the doctor, and, my cholesterol was very high. It was 300. And I thought to myself, my mother's had 300 her whole life. She died at 97. She didn't have a heart problem. I don't know what I was thinking because my father died at 43 of a massive heart attack, and my brother had quadruple surgery. But I thought, you know what? I'm a runner. My father was overweight. He was smoking Camel cigarettes. That's not me. I'm in pretty good shape. I didn't want to take the cholesterol medicine. I'm not taking a pill. Well, guess what? Now I take 5 pills. Hmm. So that might have prevented my heart attack. So I say to people, look, if your doctor tells you this is what you need to do what the doctor tells you. Believe me, you're not special. If you're really playing with Russian roulette.
That's a really powerful message to share. Thank you for sharing that. I want to dive in a bit deeper into your heart attack recovery specifically. Mm-hmm. According to the American Heart Association, 1 in 5 people who have had a heart attack will be readmitted to the hospital for a second one, as Dr. Busch was mentioning as well. This is a statistic, but we know we don't, as patients, have to become statistics. There's steps that you can take to mitigate risk. I know you mentioned now you are taking the medications that your doctor is prescribing. But what would you define as the most important step you needed to take to prevent another heart attack event from occurring?
Well, I think medication is crucial. I mean, I eat a better diet now than I did before I had my heart attack. But diet alone if it's genetic, in my case, it's genetic, diet alone is not going to help. And my cardiologist told me, look, you know what? You can't do this just with your diet. You do need the medication. I'm much more aware of what I eat. I try to deal with stress more. It's funny because after my heart attack, I happened to be at CVS buying something, and I don't know, I started talking to a woman, and I was telling her about my heart attack, complete stranger. And she said to me, well, you know what, if you started to exercise, you probably wouldn't have had the heart attack. And I looked at her and I was like, yeah, well, you know what, I was running when I had the heart attack. So, I mean, I think it's important to exercise and keep in shape. But I think that, it's diet, it's exercise, it's trying to eliminate stress, and it's keeping up with your, not only your medication, but your doctor, to go to the doctor, to have frequent, if something, when I first had my heart attack, and this is not unusual, talking to other heart patients, you're at the emergency room, like every other day almost, because you're so petrified that this is going to happen to you again. So, but as time goes on, you get a little more confident about your own body. But, you try to do what you can do to prevent it from happening again, because it's a very scary thing. I tell people, like, look, cancer is an awful thing, and I am not minimizing this. My own sister had breast cancer last year. But the difference is that when you have cancer, you go and you sit down with the doctor, and the doctor tells you, okay, this is what we found. This is what we're going to do. We're going to try this. If this doesn't work, heart attacks, I mean, one moment you're singing to staying alive, the next moment you're dead. So that is like so scary.
It's Definitely terrifying. Marianne, quick question from the chat here. You mentioned some different family heart attack history. Do you know if you have FH?
I'm not. What is that exactly? I guess I don't, because is that like?
Okay.
Go ahead.
That was
tell
just
me.
a question. Oh, it's a familial, passed down heart kind of condition. So maybe that's something we'll set you up with a cardiologist to talk about. But that was just a question from the chat.
I probably do. You know, my grandparents died of heart, and my father died at 43. And actually, my cardiologist put me on another cholesterol medicine with the Lipitor. And I guess it's for just to make sure that it stays at a reasonable rate, because that plaque is what caused my heart attack.
Well, talking some more on the cardiology team that you've worked with, and the different medications that you were just mentioning, I'd love to hear a little bit about your relationship with your care team. How often do you see them, and what's kind of been your approach with them? I've actually heard your story before. I think you did end up at Lenox Hill. Is that correct? After your heart attack in Central Park?
Yes, I did. And I was so grateful for them and the wonderful care I got at Northwell, that I actually am patient. I do patient visitation in the cardiac unit. I talk to women who've had heart attacks, and tell them about women's heart and answer their questions and more. Listen, but my first cardiologist was wonderful, but he was like 85 years old, and he retired after like a couple of months. The one thing I do regret is I didn't go to cardio rehab. I didn't even know there was such a thing. And when I asked him about it later on, he said to me, "Oh, you're in tremendous shape. You don't have to go to cardio rehab." But I think I would have really benefited from that, because it took me a while to trust my body to run again, to get on the treadmill, whatever. After he retired, I found a wonderful woman, and I love her. I would go every 6 months. She would do my EKG. She would take my blood. She was just great. Unfortunately, she's relocated. And I am now a patient of Dr. Guianos, who's one of the head cardiologists at Lenox Hill and the head of our women's heart group. And I guess I'll see her, every 6 months or so. But you really want to keep up with that, and make sure that you go and that you have a doctor that you can talk to, because I think even speaking to women who have had heart attacks, one of the things I know, and this is true in my case, is that you're very nervous and you're very scared. Of course, it's going to happen again. And as the doctor just said, it might. So you have to be comfortable enough to call and say, "Look, I don't feel right," or whatever. And, we say if there's anything wrong, you should get help, because, it's better wrong than dead kind of thing.
That's really powerful. Like a lot of other things you said tonight. Just listening to you talk about the different physicians that you've worked with, I think I'm hearing, and something that Ryan mentioned with Dr. Busch is just, it's important to be an advocate for yourself in this space as a patient. Is that something you feel like you've had to do? Is that something that Woman Heart has helped you with, kind of being an advocate for yourself in this space?
I've been very, very lucky, because Lenox Hill has been wonderful. And if I went to the emergency room, and I went about 3 or 4 times already, because I'm lightheaded from the medication, they have been great. But I have to tell you, I have talked to so many women who haven't had that experience. Very briefly, I spoke to one woman who went to the emergency room. It wasn't Lenox Hill, and she just didn't feel right. She didn't have pain in her heart, but she just didn't feel good. And she asked the doctor, she said they took an EKG, it was fine, and then they did blood work, which is really important that they do in a hospital, in the emergency room, if you think that you might be having a heart attack, because they can measure something that tells you if your heart's not quite right. And that was a little funky. So they said to her, it's not quite right, but it's okay. We suggest you see your cardiologist, make an appointment. And she said, look, I just don't feel good. Please don't send me home. Please let me stay here for the night. I just am very nervous. I live alone. So they relented. And she had like a cardiac incident in the middle of the night. She had a massive heart attack. Of course, she was in the right place and they saved her life. But if you think something is wrong, you really, really have to speak up, because, I mean, if she hadn't, she would not be here to tell me her story.
Well, thank you for sharing that, Marianne. And, you know, we're grateful for groups like Women Health that really promote, you know, being a patient advocate for yourself, you know, as well as Patch for really involved in that space. Something Dr. Busch touched on, and I just love to ask you about, is we get a lot of questions at Patch about anxiety, you know, the anxiety of having another attack. You know, did you experience that kind of feeling of anxiety, and how did you push yourself to get back out there and start running again and, you know, go to Central Park again? And, you know, how have you kind of conquered those and dealt with those different, you know, feelings of anxiety?
I don't think the word is conquer. Because I'm going to be honest, like I belong to a group online, you know, a Facebook group. And one woman said, you know, I had a heart attack and, you know, I'm very worried I'm going to have another one. It's always on my mind. And I said, it's on my mind too. You know, it's on my mind all the time. I also have a lot of tendinitis. I broke my shoulder, so I have a lot of tenderness on my left side. So I'm always like, oh my God, I hope this isn't a heart attack. In spite of feeling that way, I carry on, you know, go to Central Park. I run it. I haven't run lately because I'm having some back issues, but I exercise. I go to the gym. I pray a lot. I'm religious. So, you know, but I think most people who've had a massive heart attack are always afraid it's going to happen again, just like I'm sure people who have had cancer. I have friends who have cancer too, and like every ache and pain, they're like, oh my God, I hope it's not cancer again. I hope it hasn't spread. And I think that you just kind of live with that, you know, and you don't let it control what you do, and you try not to think about it, and you pray on it. But look, I mean, it's just the way it is.
Don't let it control what you do. You know, there's a lot of really inspirational things you've said tonight that I really appreciate. You know, another quick question that I got from the chat, you talked about, you know, the people that found you, you know, in the park and helped get you to the ambulance. And then you talked about your husband meeting there. The importance of having someone, the help and the care. Do you find that important and helpful? You know, I have known a couple of patients that, you know, just having someone to help them with their medications and stuff like that. Have you found it really important to have kind of that, you know, family and friends support system in this space after your event?
Yeah, well, I mean, I was nervous coming home, you know, and I live with my husband and my son, and just having someone there, like, you know, a couple of summers ago, I wasn't feeling well, and my husband said, you don't look good. I think you should go to the emergency room. And he brought me to the emergency room, and thank God it wasn't anything. But I think more psychologically than physically, because, you know, I don't have any trouble taking medication, or, you know, and I'm pretty self-sufficient physically. But having somebody there in case something happens, I mean, listen, my sister has a gorgeous house, but she lives in the middle of nowhere. And I thought, I won't stay alone in that house, because I think if I have a heart attack here, I'm dead. I'm absolutely dead. And I can't imagine what it would be like to be in that house by myself when her husband is out working, if I would, you know, because I just think for me, it's nice to know that somebody is there in case you have a problem. So, yeah, I mean, that's important.
Well, you know, it's important to have support systems, you know, from our care teams, from our families and friends, and, you know, definitely being an advocate for yourself is a care system in its own way. So we're kind of winding down, unfortunately, on time here. I do just have one final question for you, Marianne. I think that something that's been made very clear through your conversation here is that Heart disease is something that needs to be taken really seriously. And I'm really grateful for you really touching on that point here. And it needs to be taken seriously, both on the prevention side and the management side after an event. What is your advice to people out there who are dealing with heart disease?
Well, first of all, I want to say that I think this is so important. More women will die of heart disease than all the cancers combined. So your chances of dying of heart disease, even if you haven't had an incident, are very strong. So it's really important that you be aware of the symptoms, that you make sure you get an EKG when you go for your physical. If you've already had a heart attack, it's really important that you keep up with your medication. You really need to do that you keep in touch with your cardiologist. If it's not a person that you can speak to or you're not comfortable with them, please change, because you need to be able to call and you need to be able to ask questions. I mean, it's important to eat a healthy diet. I believe in the 80, kind of 20%. You eat very well 80%, and 20% you can have your Godiva chocolates or whatever. To get moderate exercise, just you don't have to be on the treadmill going at, a speed of 8 miles an hour to get exercise. I mean, that's very important for your mental as well as your physical being. And support, Women's Heart Group and so groups like this. I mean, it helps you realize you're not alone, and other people have gone through it also. And there's something about speaking to somebody who's been there that is very different than all the support you might receive from your family. So I encourage you to join and tell your story and share what worked for you and what doesn't work for you.
Well, I can't thank you enough, Marianne. It's been such a powerful conversation, and Patch has been super grateful for you to share your story tonight.
Well, I'm happy to be here and spread the message. I really am.
Thank you so much, Marianne. I am going to send it back over to my colleague, the Executive Director of Patch, Ryan Busch, for a final send-off. And thank you again, Marianne.
Thanks, Grace. And what an amazing conversation, inspirational. And I love this series because we have heard from both clinicians and patients from across the country who come with varied perspectives and different viewpoints on these issues. But what always comes clear through all the clinicians and all the patients that we talk to is that how important it is to be an advocate for yourself and to have hope, as Dr. Busch said in our discussion. And there can't be any better advice than that. There's hope, and please advocate for yourself. Also, I want to thank Marianne because she frankly led me out here on what I was going to say. But if you are a patient looking for support, please reach out to us at Patch or Women Heart, for that matter, where Marianne is a member. You can find all of the contact information for the Partnership to Advance Cardiovascular Health here. And if you are an organization or individual living with heart disease and you're interested in sharing your story with a goal of impacting health policy, because we work a lot in health policy, we invite you to join the Partnership to Advance Cardiovascular Health. The membership is free, and we always welcome collaboration. So thank you to everyone who joined us this evening. Again, thank you to our incredible speakers. We will see you all again soon. Please be safe and be well. Take care.